So I would like to also extend a warm welcome to all of you and thank you so much for your interest and your willingness to be here tonight. I am going to talk a little bit more about things that are perhaps more specific to what we are going to be doing in FCCT, and it's my distinct pleasure to be serving as chair of the board for the foundation. I would make one minor correction to John's comments. I don't know that I decided to be chair. I think there was some. I think there was some convincing involved on the part of John and some others. But I'm very much grateful for the opportunity to be a part of this great work. So as Mark has outlined, Tanzania and that part of Africa have a tremendous problem with cancer. I just wanted to also remind people that this is a global issue, and while cancer was at one time thought about as a problem of high-income countries, it's now the leading cause of death and disability in the developing world, throughout the developing world. 7 million cancer deaths worldwide, 70% of those occurring in developing countries. And the case fatality rate for cancers that we treat and prevent is much higher in those countries. If you take Africa as an example, the cancer incidences are quite much less than what we see in North America, about a third the incidence of cancers compared to North America, and yet the mortality rates are substantially higher, with over 50% of patients with breast cancer dying of their disease, 70% of cervical cancer, and as Mark said, Burkitt's lymphoma, which is a childhood malignancy, 75 or 80% of those children die of their condition. So there are a number of missing elements, as has already been outlined, and a lack of treatment facilities to adequately serve the needs of this population. So this is our mission and vision for the foundation, and highlighted in red under the mission is that it is our mission to enhance cancer care to improve the lives of the citizens of Tanzania, and that our vision is that FCCT will be reducing the morbidity of cancer for Northern Tanzanians through the programs that we are developing. And another way to look at this is we have three primary goals: improving access to cancer care, thereby reducing morbidity and mortality and rates of cancer in Tanzania when combining treatment with prevention and early detection. And then thirdly, of course, to raise awareness of this growing cancer epidemic and the lack of resources that are there to address cancer and other non-communicable diseases that are there. So we have set a fundraising goal for our ability to initiate this project and have some impact. We are setting a goal for 2014 and 2015 together of 1.2 million. We, as John said, have had significant commitment from many members of our board to initiate that fundraising activity, and we feel that we have a very excellent start in undertaking that project. We are working also with other collaborators, the East Africa Medical Assistance Foundation, which has been in place for many years and has helped Dr. Diefenthal with his radiology training programs in Tanzania and obtaining radiology imaging equipment. Radiating Hope, which is an organization which is working to make radiation equipment available in developing countries, and they have worked with Varian, which is one of the vendors of those pieces of equipment. Kilimanjaro Christian Medical Center in Moshi is going to be our primary area of focus to develop these programs, and of course they will be very important in our collaborative efforts. And then Duke Global Health Institute. Duke University has a very strong presence at KCMC and is involved in the medical school there, and we think can be another excellent collaborating partner. So this is just to demonstrate to you that there is a KCMC and that I have been there, and that this is the view in Moshi, which I was not able to get a nice picture of Kilimanjaro while there in March because it was cloudy all the time. But that's where it is. And these are a number of us from this foundation who attended a symposium there in March. And this is the Arusha Lutheran Medical Center where Mark Jacobson is based and will be our another part of our project. So this northern zone of Tanzania is where we are focused, and I just wanted to remind people where this is in the world. I went there in March. My wife and I went there in March, and before we left, I called the credit card company to let them know there might be charges showing up on my card in Tanzania. And the young man on the phone said, where is that? And then asked me to spell it. So for any of you who might be geographically challenged, I thought I would just point that out. And as Mark indicated to me last night when we were conversing about some things, the Ebola epidemic is far in the eastern part of the country. And in fact, I think Mark, you said that Rome is closer to that part of Africa than is Tanzania. Western Africa. I'm geographically challenged. So again, just to emphasize our major areas of focus: prevention, early diagnosis and treatment, palliative care, and then, as Mark has indicated, it will require very extensive training efforts to have the personnel available to sustain the program. And we also believe there will be substantial opportunities to undertake research, particularly from the standpoint of epidemiology and utilizing cancer registry, which has already been established there at KCMC. So the hub and spoke model is our concept, with KCMC as the primary center, the hub, and ALMC and Arusha being the first spoke. There are a number of other entities with which we would be hoping to work to raise awareness, to provide for diagnostic capabilities. Dodoma Christian Medical Center is another spot that might be down the road, a spot where we could bring more services. There are those two centers that Mark mentioned, Ocean Road Cancer Institute in Dar es Salaam and the Bugando Cancer Center, and we would see them as part of a network that we could tap into and hopefully also be able to learn from their experiences in order to apply those to what we are trying to accomplish. So as many of you know, a lot of cancer care as far as treatment goes comes down to chemotherapy and radiation. And while radiation is a very important part of much of the treatment that we provide, it requires a large capital investment in order to be able to provide those services with the equipment that's needed, with the shielding that's required. And so while we are not losing sight of the importance of that part of treatment, one thing that we have talked about more recently as a way to establish a treatment plan, a treatment program, would be to do medical oncology services, chemotherapy. And as others have mentioned, there is, I think, a tremendous opportunity to have a significant impact with a relatively small financial investment. So we need surgeons, obviously, for initial treatment. We need pathologists to be able to provide us with an accurate diagnosis. We obviously need oncologists, pharmacists, and nurses to be able to deliver the care. We obviously need chemotherapy agents and the supportive care drugs that go along with that, as well as the ability to manage symptoms, side effects, and complications of treatment. So in order to have an infusion facility, we need the providers, again, physicians who have oncology training and expertise, and perhaps advanced practice providers to assist in that. Space with exam rooms, infusion center, pharmacists, pharmacy technicians, obviously oncology trained nurses are critical. And then the ability to prepare the chemotherapy. It requires a mixing hood to maintain sterility, and also primarily to protect those who are dealing with those agents from inadvertent exposure. And storage and disposal is also necessary. So if we look at some of the common cancers in Tanzania: cervical cancer, Kaposi sarcoma, prostate cancer, esophageal cancer, breast cancer also is in the mix. And we think about chemotherapy agents that we could use, and for those of you who aren't in oncology, this is probably meaningless, but what this is a list of chemotherapy agents that have been around for a long time. They are therefore generic products, meaning they're much less expensive than brand name drugs. And there are also a number of oral agents that we use as part of the treatment to manage a number of different cancers, and some injectable agents in that category as well. But the point is that if you look at these, say, pick these cancers here, cervical, breast, Kaposi sarcoma, esophageal, and prostate, and you look at this list of drugs over on the right, there's actually 6 chemotherapy drugs and 2 what we call hormonal agents that are commonly used in management of prostate cancer, at least in the early phases of their metastatic disease. One can have an impact, and there's a tremendous amount of crossover among the different tumor types and the chemotherapy agents that are utilized to deliver that treatment. So an opportunity to provide care with relatively smaller upfront investment while we continue to raise funds and work to develop radiation therapy as part of the overall plan as well. So again, thank you for being here, and I hope that's given you a little bit of understanding of the direction that we are taking, and I will end at that point and turn things over to Charlie.